Hi, today we will continue with Miss Brown, who came to us with abdominal pain. After taking history and physical examination, which was mentioned in the first part, we start initial management. Initial management for Miss Brown can be as following. We make her MPO, we check CBC with differential. Differential looks at how many of each kind of white blood cell you have. Approximately 80% of patients have a leukocytosis and a left shift, especially an increase in neutrophils and bands. Here we see mean white blood cell counts in acute gangrenous and perforated appendicitis. Other laboratory tests can be BUN, creatinine, sodium, potassium, amylase, PT, PTT, INR, beta-HCG for ruling out ectopic pregnancy as mentioned, and UA considering urology conditions. Abdominal pelvic imagings like CT, ultrasonography, or even MRI, and we will talk about them in the following. IV fluids for initial resuscitation of unstable patients. A Foley catheter may be required in severely dehydrated patients for monitoring urine output. IV antibiotics, actually prophylactic antibiotics within a 60-minute window before initial incision for surgery should be received. Guidelines suggest cefoxitin, cefotatin, or the combination of cefazolin and metronidazole. At last, surgical consultation. CT scan is the preferred test. Low radiation dose image acquisition protocols should be used, and also IV contrast is recommended. Ultrasonography and MRI are reserved for radiosensitive populations such as pregnant women and children. CT demonstrates the highest rate of diagnostic accuracy and lowest rate of non-diagnostic examination. In the patient with appendiceal perforation, CT is also used for treatment planning. Now let's zoom on pictures to check acute appendicitis features on abdominopelvic CT scan. Enhanced double wall thickness more than 6 mm is one of the appendicitis features. Here transverse diameter of appendix is about 10 mm. As you see, here we have a thickened fluid-filled appendix. Wall enhancement and appendiculis are another features which can be seen in appendicitis. Also, appendix is descended. Appendiceal wall thickening more than 2 mm is another feature which is observable here. The last feature is preappendiceal fat stranding, which means an abnormal increased attenuation in fat. And here we can see it. There is also an appendiculis here. As we said, ultrasound is preferred in children and pregnant women, and where CT is not available. It can be performed at the bedside, but demonstrates lower diagnostic accuracy than CT. Features of appendicitis on ultrasound include non-compressible appendix with double wall thickness diameter more than 6 mm, which can be seen here on both longitudinal and transverse view. Another feature is fluid in the right lower quadrant, and there is a free fluid surrounding the appendix here. In this picture, we have a distended appendix and also appendiculis within the lumen and increased echogenicity of preappendiceal fat. A thickened appendix containing an appendiculis. An enlarged appendix with preappendiceal hyperechoic structures. Focal pain over appendix with compression during procedure is another sign of appendicitis. Now I want to show you two more pictures that contain phlegm and abscess. Appendiceal phlegm is considered to be a sequelae to acute appendicitis, which presents as an appendiceal mass composed of inflamed appendix, the adjacent bowel loops, and the greater omentum. In this abdominal and pelvic CT with IV and PV contrast, the patient was found to have a large amount of inflammation in the right lower quadrant with phlegm, as well as marked inflammatory changes including the colon, appendix, and terminal ileum. Here we have an abscess that has formed around a burst appendix. This is a painful collection of pus that forms when the body tries to fight the infection. Positive imaging indicates that treatment for appendicitis should be initiated. Non-perforated appendicitis require immediate appendectomy. But if the patient is unfit for surgery, IV antibiotics are given and we observe the patient. If the patient improved clinically, we discharge home with oral antibiotics to complete a 10-day course. But the patient should be warned that 15 to 49% may develop recurrent symptoms. And if the patient didn't improve clinically, immediate appendectomy is performed. Perforated appendicitis is characterized by a palpable mass on the right lower quadrant on physical examination, or by a phlegmon or abscess on imaging studies. In septic or unstable patients, or in the case of reperforation or generalized peritonitis, immediate appendectomy followed by 3 to 5 days of IV antibiotic is performed. In stable patients, abscess more than 3 cm or a phlegmon in which appendectomy is feasible and ileocecal resection is not likely required, immediate appendectomy followed by 3 to 5 days of IV antibiotic is performed. For drainable abscess lower than 3 cm, we drainage percutaneously with IV antibiotics. Phlegmons in which ileocecal resection is likely, IV antibiotics are given and we observe them in hospital. In these two conditions, if the patient didn't improve clinically, immediate appendectomy followed by 3 to 5 days of IV antibiotic is performed again. But if the patient improved, we discharge home with oral antibiotics to complete a 7 to 10 day course, and we follow up in 6 to 8 weeks. Do not forget that all patients should undergo interval appendectomy to exclude an appendiceal neoplasm. Our patient Miss Brown with a non-perforated appendicitis underwent laparoscopic appendectomy and discharged home. If you like this part, please like it and comment your questions. And if you would like to see more videos on diagnosis and management of diseases, please subscribe to our page.